Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sarah Reiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Kate Mihevik-Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everyone. Welcome to Interdisciplinary Case Miles. Hi, Kelsey. Hi, Sarah.
Hi, Kate.
Hi, Kate.
Nice to see you guys still. And again, we're in the same clothes, so we know that we've recorded a few today. That's okay.
We'll have more costume changes in the future. There we go.
No, it's easier for us to do this as busy clinicians, right? We have to sometimes sit down and block these out because we're with patients and doing other stuff. But today we've got a good one. I always say that, but I think they're all really cool. But this case today is a 52-year-old man who has been a lifelong runner. So he loves running. He grew up running, and he doesn't want to stop running. In fact, he had run 399 days, but then his injury stopped him from reaching 400. He went out the door on the 400th day, so I guess maybe he could count it, but it was more like a walk, and he didn't want to count it because it wasn't straight running. That's fine. So he presents to Sarah, and this is for a degenerative medial meniscus. And so medial meniscus is on the inside of the knee, and it's between the tibia and the fibula. So it's like the shock absorber of the knee. And so we have lateral, which is outside, and medial, which is inside. And the medial meniscus is shaped like a C. I don't know why I feel like I need to tell you guys that, but I do. Anyway, he presents, and he is one of those guys that's kind of stiff, like his running form is a little bit stiff when he's moving because he doesn't really do a lot of stretching because he doesn't think he needs to. So, and then he loves running so much. He wants to talk about running a lot, which is something that we love about our patients, actually, because we learn a lot. But he also he wanted to share a couple of the recent books he read and thought were like life-changing. And so one of those books is the Race Weight book. And then, so he had a lot of ideas about what that meant for his fueling and nutrition. And then he also loves Born to Run, which is a book that came out quite a while ago. And not as many people are reading it now, but it is definitely a running classic. So I'm going to pass it off to you, Sarah. That's a loaded case right there.
So I'm going to focus on the diagnostics first. So oftentimes when this person comes to me, they've kind of been able to get through all the niggles and nothing's really held them back until finally there's a little something. And he goes to his primary care doc and they get some x-rays and they say your x-rays look fine. But ultimately on exam, he does have pain. So when I evaluate him, he's got meniscal signs. So when you're doing rotational shearing across the meniscus, he has pain. Maybe he has a little bit of swelling, and that's one of his complaints that off and on he gets some swelling after runs. But it never stopped him until now. And so oftentimes when these folks make it to my office, they're like, I just want to know what's going on. Can we look at the structure? And so, for insurance purposes, generally I have to have 6 weeks of physical therapy and kind of check off all the boxes. We've tried injections and a few different things, and then we get the MRI. And I do find there's a lot of value in looking at an MRI and looking at structure for the educational piece. And so I call it peace of mind, right? Sometimes it doesn't change what we're going to do, but occasionally we're surprised, right? We don't have X-ray vision or MRI vision. And so we don't know what things look like until we get that imaging. But of course, we're always kind of doing the insurance dance to make sure that things get approved in a reasonable fashion. So we get an MRI for this person and, tell them, I'm expecting you're probably going to have a degenerative meniscus finding on there, which means that there may be some tearing of the meniscus, but it's not going to be something that's necessarily amenable to a repair. So going in and surgically repairing it. And generally, if that person went in to have surgery, they would actually debride the tissue or remove the tissue. And my general philosophy is torn tissue is better than no tissue because you remove any kind of cushion from that joint and you're going to lose the benefits that are there protecting the joint. However, once a meniscus actually has tears, it's generally not functioning like a cushion anymore. So certainly you can end up having pain. There's a lot of things we can do to reduce that and other optimizing things that we'll talk about. But ultimately, I think my first job in that particular scenario is kind of that peace of mind education. What are we dealing with? And then how do we start kind of minimizing the effects of the degenerative meniscus? If this is someone who has kind of had symptoms for a while, so it's kind of more chronic, that's one scenario. If they had like a single event and things are really inflamed, it's a little different. And so when someone has acute pain, I'll generally be a little more aggressive in terms of pain management, a short period of rest, and then getting them back out there. But if this has been chronic, then we might talk more about kind of a long-term plan, relative rest, those types of things. But absolutely, I would get physical therapy on board, seeing how we can try to improve biomechanics, improve strength, reduce irritability in there. And then oftentimes I will get questions on collagen and glucosamine and chondroitin, and what are some things I can do to keep my joints healthier? Because maybe this is someone that we got bilateral knee x-rays, which I like to do to compare both sides. And maybe both of his knee joints look fantastic. He's 52 and has 20-year-old knees. And I think that sounds wonderful, but we just can't see the soft tissue when we see the x-rays in that particular scenario. So I'll hand it over to Kate or Kelsey.
Okay. I'll take this first, I guess. So with a patient like this, I actually see or have seen quite a few degenerative medial meniscus in male athletes. So it's kind of interesting. One of the first questions that comes up is, do I need surgery? And they really want to talk about surgery because they think that if they get surgery, if they just go in there and clean it out, it'll be better immediately and they can go back to running. Because the ultimate goal here is how quickly can you get me back to running is always the thing that we're talking about. One of my philosophies is I actually don't have people stop running most of the time with a medial meniscus. I will definitely modify because if it's super inflamed, I don't want that to continue to be really hot. So the research shows that PT is about equal or similar to surgery when it comes to degenerative medial meniscus. And so that is really a patient decision. Obviously, like what Sarah said, I love this. Torn tissue is better than no tissue. I'm going to use that from now on. I do think that if you can and will try PT, let's do it. And obviously, I'm partial. But what we would do in PT are a couple different things. We would definitely look at your running form. A lot of times with a medial meniscus injury, we see a lot of knee valgus or diving in of the knee, completely loading that inner part of the knee. So we'll work really, really hard on dynamic stability. I say that a lot, but dynamic stability, working on the glutes, working on the adductors as well, making sure that that leg can control for the load that's being put on it every time that you step. So remember, when you're running, you're increasing your ground reaction force going through your body is somewhere between 3 and 5.5 times your body weight. So being able to manage that is super important. Also being able to manage rotational stability. So making sure that the hip external rotators are strong. And then I might think about like, what kind of shoes are you in? Are you pronating, over pronating? Are you pronating too quickly? Again, pronation is not a bad word. It's a good thing to pronate, but how are we controlling that foot? Because the knee is trapped between the hip and the ankle. And so we have to make sure that both of those areas are supporting the knee the entire time. So I may or may not put an orthotic in their shoe that's temporary. I don't love to keep them in forever, but if we can offload that medial part of the knee so that they can keep running, I'll do it. Anything we can to make them so that their pain decreases and they're able to run. I'll probably do some modification in their run gait mechanics. So I might work on increasing their cadence. So a lot of the articles and research that's done about cadence manipulation shows that it's really, really useful for the knee joint itself. So cadence manipulation is something that I really like to use with knee pain. And so there, like I said, there's a ton of different things we could do. Everything from modifications of your shoes, strengthening the foot, hip, core, low back, all of that, to gait changes when it comes to PT and a medial meniscus. And then somebody like this who's super stiff, I definitely want to consider putting them into like stiff guy yoga or some kind of yoga class, and maybe introducing some mobility that they might not be doing. What about you, Kelsey? Oh, go ahead.
I was going to say one more thing for the healthcare providers listening. Always take off the shoes and look at the feet, because you'll be surprised sometimes that someone will have bunions or something else that really impacts the way that the knees are functioning. Goes along with what you were saying in terms of using inserts like medial heel wedges or something to help with their knee pain.
That's right. I just assumed that we were all taking shoes off. Thank you for pointing that out, Sarah. My patients actually laugh because they come into the room, they take their socks, their shoes, their shirt, everything off, and they're just in their shorts and their sports bra usually. And if somebody else sees them after me, they're like, "Why are you stripping?" And it's because I like to see everything all the way from the foot all the way up to the head. Like I'm treating their head sometimes for lower extremity issues. So anyway, that's a really good point, Sarah, and I failed to mention it because I was assuming. Go ahead, Kels.
Dietitians, you don't have to ask people to put your shoes off. I'm not gatekeeping anything by not telling you that. Anyway, okay. So, talking about this case, it would be easy to talk about cartilage, but we already talked about cartilage today. I always talk about energy availability. It doesn't make those topics irrelevant, but I think that what we've not focused on before, I kind of want to take it a different direction of really diving a little bit deeper. And I have found it took me multiple years in my career to get confident enough to challenge this demographic of client that is maybe a middle-aged male athlete that has ran for a really long time, by the way, and has a lot of experience in the sport, to challenge them with their existing beliefs because they have got to this point for a reason, but sometimes what has got you to where you are isn't getting you to where you're going. And so challenging him on what he has learned with this race weight book, and not just this book specifically. Most dietitians don't like this specific book because it offers formulas that aren't based on actual evidence-informed information of there's no formula to calculate an ideal weight. Your ideal running weight is probably A, fluid throughout your life, and B, the result of proper fueling and keeping your body healthy enough to train. That's the race weight, and it's not a static number likely. But when you purchase these types of resources, to really look at the credentials of these people that are offering this. Spoiler alert, nutritionist is used a lot. If you're looking specifically for a diet book, look that a registered dietitian, maybe one that specializes in sports dietetics, are producing these. Or look at the background, read bios, that kind of thing. I'm sure both of you have your own version of this that you could elaborate on. But really looking at those kinds of things. And then another one would be if someone's offering promo codes into all of their posts, that might be something that spikes my spidey senses. More often than not, when someone has read the race weight book or maybe gotten another resource that is kind of insinuating a similar concept that there's this ideal weight attached to running, then oftentimes they're tracking their calories. And there was actually a newer study that came out that runners that track nutrition through apps, whether it's on MyFitnessPal or there's other platforms too, they're way more likely to underfuel. And my hot take about that is that the robots aren't smart enough yet to properly quantify all of the metabolic demands that a runner may be going to. So like, let's say this guy is 6'2" and 160 pounds, because he's spent so many years running, he's going to have more lean body mass, which is going to change your metabolic rate relative to somebody else that is that same height, weight, age. So really hard for robots to properly quantify nutritional needs. And then oftentimes too, if this person has had to modify their activity levels, they might be trying to control their intake to a point that is limiting their healing. And a lot of times, properly, giving someone in this category an extra 200, 300, 400, 500 calories on top of if they're cross training to help facilitate the healing. And then also, encouraging that, hey, body changes while you're injured is actually normal, and you fueling properly is going to allow this piece of fibrocartilage, meniscus, fibrocartilage, right? To get the nutrition it needs to heal if it's able to, or at least to heal everything else around it. And so, I would say that that's probably one of the big trends that I see with this type of client of mine.
It's really interesting that you mentioned was a hard Democrat. Excuse me. What was interesting is that when you have a demographic that you they know what they're doing and they've been doing it for a really long time. It's
Yeah.
hard to talk to them, but I do want to mention that some research came out last year that said that runners who have been running more than 20 years are at higher risk for injury because of the patterns that they get themselves into, and they don't want to change because they've been successful up to a certain point. So it's runners on both ends of the spectrum that get injured more. So I think it was less than 5 years and over 20 years, and everybody in between, kind of like the 10-year mark of running was the sweet spot of where you had the least amount of injuries. And so that just says to me, while I also sometimes have a hard time talking to clients that are really confident in what they're doing, just because they're confident doesn't mean they know the answer. And also, things change. Things change all the time. You know, I said something in the clinic the other day, and Elizabeth was like, "Oh, we don't call it that anymore." And she's so sweet, and it was so nice. But I was like, oh my gosh, I didn't realize that, because it was like something that I don't treat very often, not related to running. And I was like, oh, we're calling it something different. Cool. But it's the same thing with running. Sometimes, you know, you get stuck in your grooves, and you really might not know the answer, even if you're super confident.
Well, and the answer is our body is different every single day of our entire lives, right? I mean, 5 minutes from now, I'm not the person I was 5 minutes ago. And I always tell that to adolescents, like you have this body that's changing just dramatically all the time. You're this moving target, but every single person, and I say, oh, I'm getting older. I'm like, so are we. Every single day, we all get a day older, and we've got to be able to roll with the punches. I saw something recently that was in the REDS literature, so relative energy deficiency in sport, and I can't remember exactly how they phrased it, but I thought it was just so good because the whole point was there is no calculation. There is no lab value that tells you that you're in deficits. We don't have a perfect way, even for resting metabolic rate, to calculate that, to calculate the psychological stress that you're going through. Like there is no perfect. And so we have to use a lot of gestalt and really tuning into the body to be able to figure out what that looks like. And we're never really going to know 100%, right?
Oh, it's different for everybody. All right, guys. Well, I think this was a great case. Is there anything else you want to make sure you say before we go through our like takeaways? No? Okay. Sarah, why don't you give us your takeaway from this episode?
So, I think a lot of times when I have runners come into my clinic, their biggest interest is like, I just want to know what's going on. Like, I get sent to PT, I'm told take some NSAIDs, and I don't really understand. And so a lot of what I'm trying to do is patient education and figuring out, you know, what exactly are we targeting? What does it look like? And how can we kind of reframe so that we can move on and kind of get you to a goal of, to a happy spot and where you want to be in terms of your activity level and also taking care of your body.
Cool. Kelsey?
I think that, you know, if you're going through an injury, like it's almost like you have to put on this hat of beginning again, because it is a really good opportunity if you're kind of able to, I know it's hard for us as runners, but drop your ego a little bit and just be a little bit sponge, not that you can't listen to your body and be confident in some places, but I think that like truly, you know, you want to get back, and sometimes it's easy to build a wall up and be like, I know exactly what I need, and be a little bit closed off. But I think that like never being in a place where you can't learn something new.
Awesome. There are two things I want to say. One is we never really said what it feels like if you have pain in the area that might be medial degenerative meniscus. And so I would like to say that usually is aching. It can be sharp. Sometimes it's catching. Sometimes you feel like you're giving way, like you're when you're walking or going downstairs. So that's the first thing. I can't believe I didn't say that in the beginning, but there we have it at the end. And then the second thing is that PT and surgery often have the same result in terms when it comes to this particular injury. So you have to make that decision, but know that you don't have, a lot of times you don't have to do surgery if you don't want to, but it does require a lot of work on your end. But the other side, the flip side, is that if you do have surgery, it doesn't mean you don't have to go to PT anyway, because you still have to work on the things that caused it in the first place. And now you're going to have to think about all the post-surgical pieces like scar tissue massage and all these different unloading things. So and more downtime from running. So just kind of put it in a little perspective. Either way, you're probably going to have to see somebody like me, but it's your choice in the end. So, All right. Well, thanks everybody for listening. And like always, please pass this along to your runner friends, your coaches, whoever you might think would enjoy something like this, other healthcare providers. And if you have any questions for us, please email us at runcasemiles@gmail.com and share this as much as possible with your friends because that's the only way this grows. We really appreciate you listening and we will talk to you soon. Bye.